Welcome to Season 3 of Voices of Australia, where we embark on a journey through the heart of social cohesion. In this thought-provoking podcast series, we delve into the diverse tapestry of Australian society, weaving together the stories, experiences and perspectives that contribute to our nation's unity. From conversations with community leaders and experts in their fields, to personal narratives of everyday Australians, Voices of Australia Series 3 explores the challenges and triumphs of fostering social cohesion in a dynamic and ever-evolving society. Whether you're a seasoned advocate for social harmony or just beginning to explore the nuances of Australian identity, this podcast invites you to listen, learn and engage in the vital dialogue surrounding social cohesion. Multi-award-winning infectious diseases specialist Dr. Kudzai Kanhutu has received national recognition for her contribution to health equity initiatives. She has a particular interest in technical solutions to health problems from her experience of health innovation in her birth country, Zimbabwe, and working in rural and regional Australia. As Dean of the Royal Australasian College of Physicians, Dr. Kudzai is the organisation's chief medical voice, supporting the professional journeys of over 30,000 medical specialists across Australia and New Zealand. A vocal advocate for gender equity in STEM, her career journey encompasses technology, media, health, education and business. Testament to her commitment to community wellbeing, Dr. Kudzai continues to provide patient care in the hospital and refugee health sector, further advancing migrant social inclusion through membership of the Australian Multicultural Council. Ben is an infectious diseases physician and epidemiologist with a broad research agenda in epidemiology and the control of communicable diseases, with a focus on viral hepatitis. In 2015, he was named the inaugural director of the World Health Organization Collaborating Centre for Viral Hepatitis at the Doherty Institute. In addition to his research and public health work at the Doherty and clinical service at the Royal Melbourne Hospital, Ben serves as Acting Chief Health Officer for Victoria. Hi, Kudzai and Ben. It's delightful to have you with us. I'm really thrilled, actually, to have such incredible experts to be talking with us about health and social cohesion. So I thought we might start out simply by talking about social cohesion, and perhaps, Kudzai, you might start just talking about how do you describe social cohesion, or what does it actually mean to you?
I think it's a really interesting time to be pondering it because of everything that's happening globally and the impacts that lack of cohesion is having on the way people relate to each other. So my interpretation of cohesion as a first generation migrant, it's almost become a negatively interpreted one. For me, it's the absence of severe or pernicious conflict, as in we come together, we have differences of opinion, but none of them are at a level where we're actually not able to be well or feel safe amongst each other. So that's how I'm sort of viewing it in this moment in time.
I think that's fabulous. Ben, what about you?
Yeah, look, absence of conflict for sure, social conflict, I guess. And the other dimension to it, I guess I would put is just the depth and extent of connections between people, and maybe the diversity of those connections too. So across different ways that we might seek to describe ourselves or categorize people in the community, what is the depth and the real value of those connections and that we build, and how diverse are they?
Ah, excellent. Interesting. So how does health fit into all of this?
If you're thinking about, my perception of health has always been how safe do you feel to inhabit your own body and the spaces that you must navigate in order to take care of oneself. And that almost always infers that there is connection to others. So on the point of cohesion. So health and cohesion they're bound together. I cannot be well if I live in a community that is unwell, if I live in a place where I can't get access to the resources and the supports that I need in order to be healthy and well and have that sense of autonomy over what I can do and how I can also look out for others, because often there is that sense of if I'm well, then I can also care for others and extend that hand of support or relief or just comfort and care to others.
Okay. Ben?
Yeah, that's really beautiful way of looking at it, Kudzai. I guess thinking about health as, the WHO definitions are around a state of complete physical, mental, and social well-being, which brings in that sort of social cohesion, those social determinants very fundamentally, and not just the absence of disease or infirmity. So really that sort of positive and proactive definition of health, which I think touches on what Kudzai was saying, and the fact that we do have social well-being as being part of health, not just a determinant of health, part of what health is, really comes back to that point around social cohesion and its fundamental contribution to someone's health and the community's health.
Yeah. So one of the things we do know is that social cohesion is quite strong at the neighbourhood level. Do you think that is the most important aspect of social cohesion, as in it does need to be strong at the neighbourhood level for people to actually have the sorts of experiences you're talking about?
It's interesting. It's all of this geospatial concept of what health can be or where cohesion occurs, and it needs to occur at scale and also at the microscopic level. So personally, you can live on a street where the suburb itself is reported to be very cohesive, but you don't know your neighbours over the back fence. So there's this real sense of people are getting a very different sense of what community connection looks like compared to generations sort of 10, 20, 30 years ago, because we have multiple levels at which we consider our connectedness to others on a spatial level. There's the proximity piece, and then there's what are the pieces of infrastructure that I use within a community that then connects me to people around what you're saying around the diversity of the connections we have. So by virtue of where I am life stage, I'm quite connected to people who visit the swimming pool or the local football fields, but completely disconnected from somebody who might be very close to me physically, who just has a different way of using that space. And I think that's where I'm really interested to understand how we make sense of social cohesion when we layer on all of those functional aspects of how people are navigating those spaces that once upon a time we'd be able to just put a rubber stamp on. This suburb, people really get along well, but it's like, how are they getting along well? And is there maybe something that is really helping that sense of connection to thrive? Is it the Saturday market on the free food exchange that really helps to drive that connection, or is it something else? And I find that sort of interplay of space and how people relate to it interesting in terms of drivers of social cohesion or a sense of connection.
It is interesting, isn't it? Sort of what the availability of resources within a local area, but not just a hospital or whatever. I think I remember during the pandemic there was sort of an accidental mapping of GPs across, certainly across Victoria, and there were entire GP deserts essentially. So it's not just. Oh, was that right? It was a deliberate exercise to figure that out.
Correct.
Because I think that's a really interesting. I guess that's what I meant, was more that without the pandemic, we probably wouldn't have done that mapping exercise.
I think you're right, and the interface between what has traditionally been considered responsibilities of state and territory governments versus the federal government, and primary care, clearly something that it was viewed as a Commonwealth responsibility, but increasingly realising that actually how fundamental good primary care is to local communities, and that we do have gross inequity in the distribution of that fundamental resource that really is the underpinning of a lot of our health, at least our health care provision, and just how inequitable that is. And increasingly, since we know the huge pressure on, access to bulk billing GPs or access to GPs in a timely way or to primary care writ large, is so much worse even than 5 years ago.
Yeah, I think, and the other thing we discovered then was there became more issues around telehealth, because if you hadn't visited a GP within 12 months, you couldn't necessarily just ring up and hope that somebody would look after you. So it was really interesting. But I guess where we're going in regard to social cohesion is that mapping primary health might be incredibly important and valuable, but in actual fact, you need to map a whole lot of other types of facilities or opportunities that people have, like swimming pools or other things. Is that right, Ben? Is that right,
Public transport access. I mean, just looking at livable livable, walkable communities, and the fundamental need. I mean, that builds both health and social cohesion, right?
Yeah.
If you've got local access to schools, local access to public transport, access to healthy food that you can walk to go and buy and then take home, as opposed to having to drive for long distances in a sedentary way, which then means people aren't seeing each other down at the local market because there isn't one, right? They're all driving to the shopping centre 10 k's away. So that, I mean, when we take a health in all policies perspective on things like urban design or even public transport access, that's fundamental. But it's also fundamental to building social cohesion.
Yeah, definitely. So what are the symptoms that we see, Kudzai, then, of those people that live in areas where they don't have quite a number of those particular things? They are essentially deserts of some description or another.
Often it can be very difficult to perceive of how people are making the best of a challenging situation. So I would say we see it in ways where we look for markers of dysfunction. So we might look for trends or patterns in certain diseases, people who present with cancers later than others, and invariably they're linked to areas of socioeconomic disadvantage. We saw that in COVID, and we see it at that macro level. What concerns me is that I don't feel like we, I say myself as a health practitioner, are very good at seeing it when it's happening in the moment for an individual household or a street or a series of streets or within a pocket, that it can be very difficult to have that finger on the pulse to understand, oh, this person actually has had to travel to a market that is 5 suburbs away because they weren't able to access food that was affordable, even though they have the same aspirations we all have for eating a 5 fruit and veg a day. But the way that they have made do, and I've seen them on the street looking happy with their kids, is that they've actually had to do a lot of hard graft to make that possible. And that's, I think, something that is really hard to see, and for me would represent a real evolution in terms of how we can contend with what are the consequences, how does it manifest, those sort of primordial signs of, there seems to be people here who leave, do something and then come back. And I know there was some really interesting work done in Singapore, for example, when they had the first COVID outbreaks, where they actually tracked building workers who tend to be overseas migrants who've come into work, to see exactly how they were navigating space to make themselves, to take care of themselves, and saw the vast distances they were travelling for work, and then where they were living and where they were accessing food. And I would love to see that sort of deep understanding of how people are making do, as opposed to waiting for, Australian Institute of Health and Welfare to tell you that, oh, look at that, people in this area present, 6 years later than others, and it's because there was a GP desert. Who knew? Well, you knew, but you didn't put in the effort to put in the infrastructure that would allow you to detect those early signs of dysfunction.
It is interesting because I know when I've went and visited Mirrabooka in Western Australia, and that's a very diverse area, but many people, that might have been their arrival city, but they would then move to a different suburb. But in actual fact, in proactively trying to look after their own connectivity, they would come back to Mirrabooka to do their shopping because that's where they felt really comfortable and familiar. So they were essentially proactively trying to cater for their own mental health by really going out of their way, essentially, to find the thing that they needed most to give them that sense of belonging. Absolutely, yeah. It's what are some of the things that you think can local areas that don't necessarily have a massive amount of funding or actually recognise that they don't have the same number of resources? Are there things that they can do within that local council area to improve some of the circumstances without necessarily investing huge resources into a new recreational facility or whatever?
I'll start. Yeah, big question. So I guess, again, taking a health lens on this. So I guess one area that certainly here in Victoria and in some other jurisdictions that state and territory governments have been taking is trying to invest more in the primary healthcare responses outside of those traditional barriers of like hospitals of the state and GPs of the federal government, and the GP respiratory clinics, the urgent primary care centres. I know you're talking about community and councils, but I will get there, I promise. But I think that is part of this understanding that from the perspective of the person who's receiving these services, it's not about what does the state do, what does the Commonwealth do. It's about how do I achieve my optimal levels of health in a way that I can afford and that I can access. And so that has been welcome. And Victoria's got a network of community health centres that were absolutely fundamental to a lot of what we did in the COVID response, particularly with culturally and linguistically diverse communities, partnerships with Aboriginal community-controlled health organisations, really gave some of the examples of what, if you meaningfully partner with and invest in responses at the community level in that way, the outcomes are sort of globally second to none. It's the question of actually doing the hard yards of doing that and then maintaining those partnerships once they're built. To your point, I guess, on the what can local communities do, it comes back to your original question, which is, so is the social cohesion we're talking about, is the need for these connections purely sort of, if you're connected at your neighbourhood level, then is that sufficient? The problem with that, I think, as Kudzai was alluding to, is there are such different resources available in different communities, right? And what is possible with the resources available to the people in one local government area or statistical area 3 is just so vastly different to what's possible elsewhere. So if we have that as our organising principle of social cohesion, in fact, we could be sort of further perpetuating inequity, right? And that's the challenge. To the point on data, I mean, we know now still that there's a linear relationship between socioeconomic status and your access to COVID-19 antivirals. It's linear. So socioeconomic deciles from highest to lowest, it's a straight line, dropping access to antivirals currently, and it's the mirror line, again, straight line in terms of incidence of severe outcomes, hospitalisation and loss of life by socioeconomic decile, except if you look at culturally and linguistically diverse people, it's the same relationship, but it's shifted down. So higher mortality and lower access across all of those dimensions here in Victoria. No different anywhere else in the country, I'm sure. So there are such fundamental social determinants, not just in health, the risk of adverse outcomes and the risk of chronic disease, etc., but in terms of healthcare access and the outcomes, it is so stark.
Yeah, it is interesting. So Kudzai, I know you're on the Australian Multicultural Council, so just picking up on some of these pieces that Ben just mentioned, there is but two sides, isn't there? There's the availability of options, and those options need to be ones that generally people from a whole variety of different backgrounds would actually see as options. And then there's awareness, and whether or not it's particularly around actually not particularly around anything, but generally the awareness of whether or how severe a particular symptom might be varies depending on which particular cultures you come from and how you've been brought up, as to whether or not you should or shouldn't admit or even act on that view. And I imagine that some of that is exacerbated by the lack of easy places to go to find out and ones that you feel comfortable going to. But are there things that we're not really aware of that can help with either awareness or access?
I would like to draw the distinction between awareness and experience, because often we talk about and obsess about, there's low community awareness of a clinic. We're not aware. There were people who were not aware that they could go to a respiratory clinic and just do a walk-in. What do we do to get to community? Do we go to the churches? And what we forget as practitioners or providers of the support is that we are not aware of what that individual's experience would actually be like when they turn up. And time again I hear of, I was told to go to this clinic, but when I turned up, I was asked any number of questions. There was no attempt to make that a welcoming and a positive experience. So what you end up with is a community awareness of, there's a clinic on that street. It was horrible. It wasn't for me. And that is the awareness loop that you've just raised, because you failed to do that work of partnership at the front and at the beginning. And it's an iterative cycle that says, we will build this thing and we might have to do it quickly. But somewhere along there, we are actually asking those questions and observing keenly so that we are aware of the harm that we might be causing by providing a service that is not fit for purpose or providing a service that fundamentally actually relies on informal networks in order to thrive. Yeah. So it's there, but we know that in order to get there, you're going to need a lot of supports, and we don't actually do that thing at the person arrives with somebody. Do you need a certificate? Because where have you come from for you to be here? Or what else has happened in order for you to be here? And how do we make that a very explicit conversation around informal networks that support the infrastructure that we have built for people to make it a respectful and a reciprocal relationship, so that people come with an expectation of care and also of being seen in full, and also of being asked at the end of the clinic, how was that? Was it horrible? Did you feel, humiliated while you were waiting, or if somebody shoved you a mask, or you were a bit confused or bemused when you arrived? How was it? And is there anything we can do to make that a better experience, so that the community awareness that you then raise is, it was great, do it. Go to that place. They really cared for me, and they understood what it would be like to turn up to try and receive care here.
Can I ask a question? Yeah. So Kudzai, what was your experience, particularly thinking about some of the community health centres and the employment of health concierges and bicultural workers who were expressly there to try and build some of that sense of comfort and to bridge the gap between some of the service systems we set up and the communities that we're setting them up for? And is that something that, you think has continued to be invested in?
I'll start in reverse. So I think it's underinvested in, and it's often done very quickly. And the people who are, co-opted in, there doesn't ever seem to be any process of ongoing evaluation of who was co-opted in, what was their experience of having sometimes that cultural or social burden of being the person. Because for many people, particularly in small ethnic groups or communities, that work doesn't stop when they leave, because they then get known as the person. If I don't feel who's got the job in that area, I'm going to ask them, or I'm going to text them, and I know they're on this WhatsApp group or this Facebook group, and I know I'll contact them when I need something. And it's that.
They're also often casual, as in they're not necessarily seen as a priority. They're there, and they might be individuals that are job sharing. I know we've seen that at a hospital just recently, who got one salary and they're trying to maximise it in as many ways as possible. So it's not
consistent infrastructure. It's not consistent infrastructure in the same way. So if you turn up at a clinic, you expect there to be a receptionist. Not some days there's a cultural concierge. Other days there's not. What culture are they? What protection or support do they get, so that they can, have a sense of boundaries for themselves around, it's okay if you're telling us that you're getting home and you're working, maybe we actually need to consider some sort of on-call rate for you, because what you're doing is actually an on-call job. And if you can just find a way that is respectful to reflect that work, then we can look at building that service in a way that is sustainable. And that might mean, services like Health Direct or some of those on-call sports, getting that feedback from that, the state level of government. So we know there's a national program. What we've observed is that there is a huge unmet need for this type of phone advice or support in this language, because that's what our bicultural workers are telling us. Yeah. Is there a way we could escalate that as a need for some of those on-demand, very sometimes impersonal services, but it's something that extends that, and so that individual who has that burden of I'm the bicultural worker can be a bit off, can be like, okay, I've fed that up the chain, and somewhere along the way things are going to change, and there will actually be someone else who can carry this with me, and it's seen as opposed to being completely unseen.
But Ben, you do make a really good point in that, in actual fact, health and the health sector has actually been, because they are at the forefront of meeting individuals and people, they actually have to deal with a lot of these issues and respond to them. And so sometimes health departments are very much at the forefront of how we should be doing things better and introducing things that others haven't necessarily, that work across the other areas of, transport or housing or whatever. They haven't necessarily caught up with that particular need. So it's quite interesting about thinking about social cohesion and all of this awareness that needs to take place about how everybody playing a part in building that. So are there things, so a number of those things were put in place because of the pandemic, that there was that urgency that was and needed to be. But in actual fact, hasn't necessarily perpetuated beyond that? And do you think there's this bungee cord that pulls us back to the old way we used to do it? What are the things that we should be doing to make sure that we actually continue to build as a country that is as diverse as we are, to build on the stuff that really did work during the pandemic?
So if I could give two examples, one that I think has sort of continued and I hope will continue to be part of how we do things differently now, and one that maybe is has ebbed. Mm-hmm. So firstly, I guess in recognition of the need to deliver particularly public health responses at the local level during the pandemic, and obviously at a time of great challenge, Victoria created the 9 local public health units, which are charged with response to communicable disease, so for health protection, but also for broader health promotion and prevention activities at the local level. And this is new. This has not been done before in Victoria. And so they started up during the midst of the acute phase of the response to the pandemic, have had a really strong role in our pandemic response. But then in further sort of both local responses, I'm thinking things like some of the challenges we had with mosquito-borne diseases and some of the health consequences of flooding, etc., but also just the day-to-day work with community. So those local public health units continue and I really think are continuing to deliver in a way for Victoria that has not been possible before. So that's really exciting. Yeah. And that's a continuing investment in that sort of locally informed and connected public health approaches that are seeking to integrate with primary care, with tertiary care, with community organisations, definitely with councils as well. So that's a strength. I think one of the areas, and I was sort of asking about the health concierges, I think we learned particularly through the response in 2020, but then really proactively in 2021 with the vaccine program, sought to partner really both respectfully but also guided by community about best ways to get vaccine messaging out, to get vaccination models that were suitable for communities, whether that was particular faith groups, particular cultural groups, particular areas. And we invested in that. And, you know, we had amazing success in vaccination drives at faith-based schools and religious centres, at local councils, at schools, communities, everything, alongside primary care, which actually did a huge amount of the vaccination drive, was the reason for the mapping we were talking about before. So I think, and with both partners and community champions and faith leader champions for vaccination. Now, again, it wouldn't have been possible to continue with that degree of focus ongoing, but I am concerned that those partnerships and those really strong, respectful, genuinely two-way discussions around healthcare delivery, particularly to Victoria's culturally and linguistically diverse communities, and preventive health sort of priorities, that with the necessary need to sort of step back from the acute phase of the response and obviously the budgetary realities that all governments find themselves in, I am concerned that some of those lessons and some of that real partnership is being lost, and that does worry me.
It would be nice to be able to figure out if there's a model by which they can ramp it up and then release it depending on the situation, because my understanding is that vaccination rates have actually dropped on other things like flu vaccinations and things like that are not as high as you would have liked them to be.
This is a global phenomenon we've seen. This is not, and it's not just here in Victoria or even in Australia. So whilst those partnerships, I'm really proud of the work that the Victorian the COVID response did and continues to do, in the public health and primary care response. I think some it would be great to see some of those partnerships be strengthened and built on, and that's on all of us to do.
So Kudzai, you're familiar with the Measuring What Matters, or effectively the wellbeing budget. Do you think that is, what do you think of it? But in actual fact, do you think it could enable this sort of more cross-sectoral thinking about health in relation to all sorts of other elements that play out?
It does provide a foundation for at least setting a baseline of who you consider to be your key stakeholders. So everything we learnt around how people are connected to institutions was incredibly helpful to the COVID response. But the feedback that I'm sure you would have had consistently was, well, we'd never heard from any of these agencies before, and then all of a sudden they were all over us with money and requests to meet, and then once the crisis has died away, there hasn't been that thinking around how do we maintain that level of connection. And I think there are some really simple and pragmatic ways. We know there are always going to be at community or council level, there are grants. And those would be those moments where we say, look, every now and then, thank you so much for your support, whether it was a church group or a sporting group. Twice a year, we're going to hold a forum where we bring you in and we tell you about some of the opportunities that are there to support you in your work and to hear and to have that listening ear. It doesn't have to be over-engineered. It's just creating those spaces where you have that contact list. And it's something, business does really well. You maintain a list of key stakeholders in your customer relations management system that says, we think we have a good sense of what the ecosystem looks like, and we know that if we needed to ask a question about a particular group, whether it's an emergent group, this is where we might go looking, but we maintain that as an active directory. And it's that sense of having an active directory as opposed to a legacy directory that is born out of COVID and then you realise, oh, those people moved to a different suburb, it's not there. Maintaining that active directory firstly requires you to maintain some level of contact, pick up a phone. Call, ask, is this still going well? Are there any needs you have? Oh, by the way, there's actually a grant that's specifically being targeted for that. And there will also be a grant writing workshop. And in saying that, I'm also mindful of that tension of people who are basically begging for funding all the time or spend a lot of their energy trying to beg for funding to get across the line for the next community event. And it's about also turning those begging instances into fixed funding and formal funding as opposed to leaving it to the scraps and, the rubble of people having to continually be in a perpetual funding cycle loop that you should at some point see this is always really well clearly taken up. Let's translate that into the next budget because we've seen that these ones are really well taken up and we're in a growth corridor in this direction. And for that reason, we're actually going to establish as a fixed service.
So do you think having a national framework with specific indicators is something that would actually have a trickle-down effect in essence, that we would be seeing more activity going on to meet those particular indicators that's happening at a local and a state level?
Yeah, and it's also the partnership around what indicators are you looking for? Because there's a lot of, in that unseen informal network, there are lots of things that I think you could glean if you have the conversations with some of those, informal community concierges who will tell you, actually, there is an issue here with family and domestic violence. We know that there are 5 women in this community who regularly have a room in their bed, in their houses free for somebody who needs somewhere safe to be. It's getting to that point where we can actually tap into that and understand it. And it's the sort of thing that tends to happen at the PhD thesis of someone will do a PhD and discover all these things and then it gets shelved somewhere, but we haven't taken that moment to learn from that and say, look, how could we detect if this is happening in our communities and then have that be the starting point for a conversation or a dialogue to find out what it is we could do to support or to help people who are in that situation of holding up.
Now, we've talked a bit about sort of primary care, but what about when it comes to mental health and sort of the preventative elements around mental health? That's a little bit more amorphous, if you like, a little more ethereal to figure out exactly what the things are. But when it comes from a social cohesion perspective, we want to be putting things in place that are actually going to contribute to people's mental well-being. And have you got any thoughts about how we should be trying to address that?
Oh, there are some phenomenal examples, and particularly in the last 5 years, I would say, of people in the African diaspora community who have actually gotten to the point where they're setting up their own businesses. And that has been for some of them. So I'll speak of Selba Gondoza-Luka, who works in everyone knows Selba, right? And that is a story of just somebody who decided through their own experience that they were going to work so hard to create a safe space for people to talk and discuss mental health. And it's very hard to do it for Africa, because what is Africa? But it always kind of gets lumped into it's African community. And I say that as somebody who sat at the Kenyan table at the Africa Gala Day, and I was like, oh, I feel really lost here. But there are very clear examples of people who are doing it and doing it well. And they're doing it often with some unique partnerships. For example, I know Polar Health in Ascot Vale, again, another Polar Psychology, another example, completely overwhelmed on their books with people who just did not have anywhere to go. It's the conversations with them and the experiences and the partnerships that they had with the Melbourne Business School around how do we establish the business, how do we market it. And this is just taking people who have all of the intellect, all of the will, who just need to say, look, this is what I need. Who can provide that so that I can get on with what I know I'm perfectly capable.
But the interesting thing there, though, is more to do with the supply chain. Yeah. Effectively, there are not enough people with lived experience going through the process of becoming psychologists or psychiatrists. So they're sort of resource constrained in people that can actually cater to their specific communities.
And I wonder, though, if it is always a case that you have to have somebody with lived experience, because it is about finding the right patient to clinician fit. Yeah. And I have had people who I've cared for who are Zimbabwean, and it hasn't worked. Mm-hmm. And it doesn't work for any number of reasons. So I would maybe challenge that by saying it's great to have people who have lived experience, but you can also learn to empathise and to connect with your clients on a level that will meet an individual's needs. And that's where, and if you set up the clinic right, and Polar Health have invested a lot of time and energy to setting it up right so that people feel truly welcome, truly seen, you can coach a practitioner to get to that point and make sure that you're keeping them, I guess, at the frontier of best practice for that space. Because if you wait for there to be enough people with lived experience, nothing gets done and people are missing out on progress.
And I'm really glad that you mentioned that, because I think that's absolutely true. The nice thing about Polar is that they're actually developing guidelines for practitioners regardless of their background, so that they can actually be more aware of what the situation might be, or the respectful nature in which they need to engage with whoever walks through their doors.
But absolutely, we build the pipeline as well. And I know the government have done a lot of work in trying to create opportunities for people to come into the health space, into nursing, but it's also looking at how do we encourage particular types or groups to get engaged and involved in this, in a particular field when you've identified that there's just a huge gap. You've got to absolutely build the pipeline, but until you can make that a full and robust one, you just have to find other ways.
Ben, it plays out in the research side of things too, doesn't it? That there's has been, from a gender lens, there's always been a preference to go for men because they have sort of somewhat less tricky things going on in their life from a research perspective, whereas now we're moving more into doing more research into women's circumstances. There's a lot of other research components that need to be investigated in order to be able to inform GPs or whoever.
Yeah. And just that, that is a fundamental question, and something that I know that has really been done poorly in the past, and there is now more express focus and thinking about just because we're conducting research in certain groups because it's either easier or more accessible, or you can get around concerns around pregnancy if you're doing a biomedical research project, an interventional study, etc., and therefore whole sections of the population get excluded from proper consideration of how conditions may manifest differently in them. But look, mental health, thinking about loneliness as a risk factor and coming back to social cohesion as a fundamental and incredibly significant risk factor for both, well, obviously for social, but for physical and mental lack of well-being and ill health. And that is something that no health system can address. That's for the community to address. And how do we address loneliness in our community is a big question. But I agree with Kudzai, the state has responded and continues to respond with historic levels of investment actually in mental health, in recognition of deficiencies of the past. But I think in parallel with what the states and territories do, again, we know that from a clinical provision point of view, most mental health care is actually occurring in primary care, in general practice and primary health care, right? And so if we've got people with lack of access to primary care, then they will lack access to mental health care and to all the other parts too. So I think it is multifactorial, but you know, in partnership, we just have to find ways of doing better in this space. And I'm confident we will, but it will take time.
So we have just to finish up, we have quite a diverse group of people that are listening to this podcast. So if they wanted to do something within their local area to make a contribution to helping others, any advice? What would you suggest that might be something that an individual could actually do to foster social cohesion where it relates to loneliness or isolation?
Look, everybody has resources, and it's about getting a sense of what your resources are. Some people have time, depending on where you are career-wise. Some people have money. Some people just have the gift of conversation or connection. But at the very least, I think everybody should be in a position where they can map their neighbourhood or map their local area to understand what is already there. Mm-hmm. It's having that connection or that meeting with council to say, what programs do you actually have that are running? Because often there's a lot going on and people just haven't asked the question. Is there something for a particular community or an age group? And you'll often find that there is, if you have time to give, there are volunteer opportunities. If you have money to give, there are money opportunities. And then there are those moments where you get to exercise your democratic right. So when it comes around to, because you've understood your community, you've understood where you stand in that and what it is you have to give, when it comes to the ballot paper, you're actually thinking proactively around what are the statements people are making that would lead me to believe that they will help to support and to give rise to thrivership for the things that I've seen in my community that are positive and are good. Not everybody has to start their own not-for-profit because that's often where it goes to. Like, I'm going to have to sell my house. That's not it. Understand where you are. Ask what's happening. Ask what is needed, and before too long, you'll find many, many ways that you can help. Even if it's just a tin of beans for the local food drive. If that is what you can do, is that the level of your resource, that's fantastic. But you must know your community first before you can sort of start to think about where you might act and where you might be a positive contributor to that.
Yeah, look, I fundamentally agree with all of those points. And I think, again, finding the opportunities for I know that volunteering is at its lowest ebb for a long, long time as a proportional involvement. And there's a lot of determinants of that. And, people are really busy and cost of living crisis and people working multiple jobs. These are real pressures that our community faces, every community faces. I guess the other thing that I would put, and this might sound a little bit simplistic, but I actually think it's important. We've seen in our society, in societies around the world, this increasing polarization, and that builds, that hardwires loneliness, and it's part of the social conflict that can undermine social cohesion, to Kudzai's initial definition of what you view social cohesion to be. So even if it's as simple as disagreeing with people in a respectful and a kind way, and us all consciously taking a step and say, well, I might disagree with something, but I'm just going to put that I disagree with it, and then utterly defend someone's right to disagree with me, and do that in an open and a constructive way. And I think if each of us does that, instead of sort of flying off the handle and saying, well, of course you should get vaccinated, or of course primary care is important, or whatever, just step back and say, okay, I understand you're coming from a different spot from me. Yeah. Let's chat about it. And that might take a little bit more time, and it means that but that is the opposite of disengaging. That's engaging in a positive way. Yeah. And I think I certainly could do more of that. Respect and connectivity. It's incredibly important. So thank you both very much for spending this time with us. I'm absolutely delighted to have had the chance to have such a great free-flowing conversation. So it's been a real pleasure. Thank you both very much. Thank you for listening to our Voices of Australia podcast. For more episodes like this one, you can visit the Scanlon Institute website at scanloninstitute, or one word, .org.au.